I'm really excited to introduce Dr. Monica Mindt as our speaker for our General Internal Medicine Grand Rounds today. Dr. Mindt is a professor of psychology at Fordham University and also holds a joint appointment here at Mount Sinai in the Department of Neurology, where she conducts most of her clinical research, which has been funded by the NIH and by the Alzheimer's Association, and focuses on the intersection between cultural neuroscience, clinical neuropsychology, and health disparities, using a novel community-based approach. And she has authored more than 60 peer-reviewed publications. She has received numerous awards, including Professor of the Year from Fordham University, as well as the Early Career Service Award from the National Academy of Neuropsychology, and the Distinguished Alumni Award for Psychology from Pepperdine University. A fun fact about her that you've already heard about is that she is an avid surfer. So welcome, Dr. Mindt.
Thank you so much for that nice introduction. I appreciate it. So good morning, everybody. It's so nice to be with you here today, and I want to thank Dr. Fetterman for extending this invitation. So you already know a little bit about me, so let's talk a little bit about what's happening today. Is this going to work now? It was working before. Oh well, we'll go the old-fashioned way, maybe? Here, let's see. Okay, great. Okay, so here's the lowdown for what we're going to be talking about today. Health, culture, disparities first, then brain health research in my area of HIV and aging, and then we're going to try to disentangle some of what that research might really be getting at or what's underlying it, and then discussing next steps. So I'm actually I don't know why I did this animation. So there we go. Okay, so before I start talking about the research, I want to tell you a brief story. So the reason that I got interested in culture and brain health disparities is a result of a single person case study, myself. And this case study took place over 8 years. And in the span of 8 years, I lived in all 5 regions of the continental U.S. Okay, so just because of wanderlust, because of my education training, for a number of reasons. And so I went from the Southwest to the South, and then to the Midwest, to the Northwest, looped back down to the Southwest, and then ended up here in New York City. And what I found from that experience, it was an extraordinary experience to see America in this tight, this kind of tight time frame. And what I learned was that there's a lot more to race and ethnicity and associations with neurocognitive functioning than I had initially been thinking about, had been trained on. And some of the things that I saw during my travels across the country were that growing up in Southern California as a Latinx kid, so I grew up in a low SES, difficult circumstances. I'll just leave it at that. And I thought that was unique to being Latinx or maybe other people looking like me, brown or black or what have you. But when I lived in North Carolina, I found out that I had a lot in common with rural, non-Hispanic white individuals living in the Appalachian Mountains who were facing similar challenges in terms of SES and access to healthcare and experiencing issues in terms of cognitive functioning. So that got me thinking. And then I went to the Midwest to train, and I learned again that culture is a lot more than what we think about in terms of race, ethnicity. It has a lot to do with the region that you're from. It has to do with religion and other things. And I started getting a sense of dimensions of culture. And then when I worked at the University of Washington doing my residency, I worked in a refugee clinic. And while working there and doing cognitive testing with refugees, one day I was working with an interpreter doing a referral with an older gentleman from West Africa. And as I'm doing some testing with him, one of the tests that I give him, I ask him, okay, now I want you to do this test as quickly and accurately as you can. Go. And as I give him that instruction and it's translated to him, suddenly this very compliant, nice older man, he started busting up. He started laughing and laughing and laughing, and I'd lost control of the cognitive testing situation. I thought, oh my gosh, here I am, this inexperienced resident. What did I do wrong? I'm freaking out. And I asked the interpreter to tell me what's going on. And what I got in return was, silly girl, I can either do it fast or I can do it right, but I can't do both. And then it was like, the construct of time, right? And how we approach problems is different depending on where we're from and how we're raised. And there's cultural neuroscientific research to back that up. And suddenly, by the time I got to New York, this took me to this path of getting really interested in issues of culture and health and how they might interact. And so on this slide, you see a summary of how I think about health, in terms of being more holistic and broad than just a traditional, physical health. When I say physical health, I have that little asterisk there because I'm also thinking about brain health, which I think people are not talking about enough explicitly, and there are lots of reasons to be paying attention to it. You see the whole definition there, so I'm not gonna repeat it. But health is about more than just what we traditionally consider. So it's mental health and all of these other aspects that contribute to our physical well-being and our overall well-being. And I believe that part of my travels really made me think more about that intersection between health and culture, because what we know is that there are many different types of cultures, and that cultures influence our attitudes, our beliefs, our behaviors. And if we as clinical researchers or healthcare providers aren't thinking about that intersection, we're missing the boat and we're not doing a service to our participants and our patients that we serve. So what I've come to find in my years in research is that there are a number of challenges to both research and practice in brain health. And here I set out what I think are my top 6. So the first is our traditional paradigm of brain health. So this is the way, so I was taught research in a very traditional way. So really good research training, but very traditional. And what I mean by that is that in my training, what I learned is that we have a brain, that's our hardware, and that from that hardware, we have cognitive functioning, we have behavior. So this very linear, universalistic view of brain behavior relationships. And what I found was that this model really seemed to be missing the boat in terms of acknowledging and incorporating other aspects of what could be impacting the software of the brain, the way the brain actually functions, which is culture. So that's my headline, and we're going to get to that in a little bit. There are other challenges as well. So the U.S. demographics. So we know that the United States is getting increasingly and quickly more diverse, right? So 100 years ago, something like 1 in 8 American people living in the United States were from a racial ethnic minority background. Today, it's 1 in 3. And by, I think it's 2025, it's going to be like 50%, right? We're going to have minority majority. And we also know that if current projections hold, the Latinx population is going to be about a quarter of the population in the coming years. We also know that not only is our country getting more diverse, that the older population, so 65 and older, they're also becoming more diverse as well. And so here you see that by 2060, the proportion of individuals from racial ethnic minority backgrounds is going to double. However, our workforce, our research is not ready for those challenges. And what we see in our country are significant disparities. So we live in a racialized country, right? And as a consequence of that, there are significant disparities in research and in healthcare. So healthcare is not doled out equitably, access to healthcare, and also utilization of healthcare is disparate. And so what I mean by that is that groups from disenfranchised backgrounds, socioeconomic and others, who would be disadvantaged for different reasons, have worse health. So not only are they less healthy in our country, for instance, when I talk about HIV and other things, but once they contract an illness or a particular condition, they have worse health outcomes. Right? And so what we want is to get to a state of health equity in our country, right? Where so there's this equity in everybody having equal access to good health outcomes and not being disproportionately impacted by illness. But we're not there yet. And so that's a lot of what my work is about. And what I found surprising in my field, so I'm a again, as was briefly, thank you again for the introduction, discussed, my work focuses on the intersection between cultural neuroscience, clinical neuropsychology, which is the study of brain behavior relationships, and health disparities. And when I got started in this work about 15 years ago, there was really no focus on the fact that individuals from diverse backgrounds were experiencing worse health outcomes. But the research is growing, certainly in the last 10 to 15 years. And what we know is that individuals from diverse backgrounds are at greater risk for HIV, which I'm going to talk about, for Alzheimer's, for vascular dementia, and other risk factors that put them at their brains at risk for poor outcomes, right? And as a consequence, care providers, so neuropsychologists, physicians, anybody working with people, they're more likely to encounter people from racial, ethnic, minority backgrounds who are at risk for brain health problems. Okay? Are you with me? Okay, bueno. Okay, great. All right. And so you might have seen this slide before, but the issue of social determinants of health in the field of brain health and neuropsychology has largely been ignored. So this has been a major challenge. So even though population science tells us that the majority of the determinants or predictors of population health have to do with sociocultural characteristics and the total ecology of the environment. Even with that information, the field of brain health research has been slowed to look at social determinants of health, which again has held back our research. And then there's the issue of ethics and ethos. And so these are the ethical principles from my field of psychology, but I'm sure in medicine you have similar principles and ethics that have to do about the need for justice in what we do, that individuals have recognized that fairness and justice entitle all persons, regardless of their background, have access to and benefit from the contributions of our science and our practice with equity, and that we as providers and researchers take into account our biases, consider the boundaries of our competence and the limitations of our expertise so that we don't perpetuate unjust practices. However, what I'm really, I don't know exactly about general internal medicine, and maybe you can edify me, but in my field of neuropsychology, I have been astonished to see how cavalierly people in my field will work with underrepresented minorities where they really don't understand the instrumentation that they're using or really understand the cultural or linguistic issues, and then just assess and diagnose them like everybody else, like majority culture, like in a cookie cutter way. And really, without accounting for sociocultural factors, we're really drawing bad conclusions based on bad data. And so there's this significant challenge of ethical issues in my field, and I think in the broader field of brain health. And the last thing I'm going to talk about is the challenge to our science. So in order to conduct empirically based treatment, we need to have a good empirical basis from which to draw. And prior to, again, about 10 to 15 years in this area, there really wasn't a whole lot to look at because nobody was thinking about it. Again, we're taking this cookie cutter approach to brain health and understanding brain behavior relationships. So the first problem I see in terms of the empirical basis in brain health research has to do with this conquistador approach to research, which basically, so what does that mean? So I do community-based research here in Spanish Harlem, and what I've seen and thought about a lot is the fact that many times researchers from the proverbial ivory tower come into these vulnerable communities, and then what do conquistadors love? They love gold, right? And research conquistadors love data, right? Because that means papers and grants and the glory. And so they take that gold, put it over their shoulders, and then run off, and they leave that community high and dry where they got those data. And this is a self-perpetuating cycle that I think is a real problem. And some people now, I've heard more recently this idea of helicopter research, right? And so this is a problem because research in brain health isn't informed by the community, it isn't tailored to the community, and it doesn't benefit the community. And I take exception with all of those things and try to take a different approach to my work. Also, in general, we know that there's underrepresentation of culturally and linguistically diverse individuals. We have limitations to our instrumentation. We have a pipeline issue because we don't have enough diverse researchers in the field, but even beyond that, this notion of cultural competence, that's for everybody, no matter what your background. And we have a capacity issue that we haven't trained our researchers and our clinicians well enough so that they can conduct culturally competent research and practice. And so together, we have a number of issues that we need to contend with. So how do we approach these critical challenges as we think about brain health and improving the brain health of all Americans here in the United States and really all over the world? Well, what I would submit to you is that we need to start focusing explicitly on brain health in underserved, underrepresented communities. And I've done that through my research, it starting in HIV. So why do I study HIV? Well, one reason is that it's a neurologic disorder as much as it's anything else. So I think a lot of times when people think about HIV, they think about, of course, the immune medical consequences, but it turns out that HIV has an affinity for the central nervous system. The virus gets into the brain early, even before we might see other medical or physical manifestations of the illness, and it can cause significant impact. So it can cause HIV-associated neurocognitive disorders or HAND. And it turns out that based on research from myself and colleagues from all over the country, even now in the post-CART era, so even in the era where we have improved medications for HIV and people are living longer, the prevalence of HIV-associated neurocognitive impairment continues to be high, about 50%. And here you see the different classifications of impairment, which can be as mild as asymptomatic impairment, where yes, somebody's having cognitive problems, but they're not impacting their everyday functioning, all the way to major neurocognitive disorder, which is our term for dementia. So full-blown dementia because of HIV, not because of anything else, just because of the virus. And it can cause a whole host of neurocognitive impairments. It really focused on frontal striatal functioning. So things like executive functioning, so problems with problem solving, higher order reasoning, problems with attention, concentration, learning, memory, how quickly you can think and process information, and motor abilities. What also is interesting to me about HIV in terms of investigating this population is that there are significant health disparities. I'm not sure if you can see this, but basically the gist here is that currently, or as of maybe a couple of years ago, about 26% of the U.S. population is either Black African American or Latinx, which is the U.S. population pie chart on your left. However, in terms of the HIV population here in the United States, about 65%, 2/3 of the population is either African American or Latinx. So not only are racial ethnic minority groups disproportionately infected, so they're infected by the disease, but once they're infected, they're more affected by the disease, which makes it a health disparity. So let me show you what I mean by this. So here's some background about why I focus on this population. I think they're important. But in terms of HIV health disparities, so they're, as I mentioned, compared to non-Hispanic whites, they're at greater risk for infection. They have higher rates of NP stands for neuropsychological. They have greater rates of cognitive impairment. They have greater risk for functional problems like worse medication taking accuracy. A colleague of mine up at Einstein, Julia Armstead, published that work. They also have greater risk for peripheral neuropathy. And that study was done with my colleagues here at Sinai. It turns out that Latinx HIV positive adults have greater risk for peripheral neuropathy than not only non-Hispanic whites, but also African American HIV positive adults, right? They also have higher mortality rates and they're more likely to die at a younger age. So we have significant disparities that should cause us to think about this population. Am I doing on time? Okay. So in terms of brain health disparities, so this is a paper that my colleagues and I conducted from the Charter study. So this was multi-site national study, 6 sites from all across the country, including Sinai, UC San Diego, Texas, University of Washington, Johns Hopkins, and Washington University in St. Louis, so all over the country. And we looked at differences in neurocognitive impairment in the Latinx segment of the population. And I'm going to go over quite a number of studies, and my purpose here is to give you a survey, like a macro level view of the literature and what's going on. So I'm not going to get into the weeds because I want to cover more. But if you have specific questions, I'm happy to answer them, or I can send you the actual papers. Okay? All right, so here, I hope you the slides okay, but what these figures show, let me come over here. So this figure here shows differences between non-Hispanic whites in the plain bar and Latinx adults in the striped bar. And across a number of domains, as you'll see here, when we do these between group comparisons, we found that our HIV positive Latinx participants did significantly worse than the non-Hispanic white participants. And that's after accounting for things like immune function and other demographic characteristics that could be confound. So we accounted for education. You might say, well, what about education or other things? We accounted for that, okay? And even with that, we saw that the prevalence of impairment was significantly higher in terms of global neurocognitive function when we think about like all these different domains, and specifically in executive functioning, again, how well people problem solve, right? Novel reasoning, processing speed, learning, memory, and attention working memory. So across most domains, we're seeing these significant differences. So in fact, the only places we didn't see differences were in verbal functioning, right? So it wasn't just language that was driving these differences, which you might call me out on, and you should, but it wasn't just verbal functioning. And motor skills, here, they were similar with gross motor skills. Okay, so we see between group differences, and I, myself and a couple other colleagues have shown this with smaller studies, which I'm going to show you in a second. But even on this large national study, we see significant differences. So that's interesting. But we wanted to get a more finely grained look at this. So then we did a within group study, because I think part of the problem with research is that oftentimes we just look at between group differences between, whatever the minority group is with the reference group, which is always non-Hispanic whites. But really, if we want to start disentangling what race and ethnicity is, because we know that race ethnicity, this is a social construct from that was derived here in the United States and other places for a number of sociopolitical reasons, which I'm happy to talk about. I can go back to Thomas Jefferson. I'm really psyched about that. If you want to do that. But by only looking at between group differences, we don't deconstruct why are these differences really occurring. So my colleagues and I, we compared Mexican-American Latinx individuals who are mostly from the Southwest to primarily Puerto Rican individuals who are mostly from here, okay? And look at what we found. So we found that, so a lot of the differences driving these between group differences are really derived from here, from New York City HIV positive Puerto Ricans. So take a look. So here now the bars, so the striped bars are Mexican participants, the solid bars are Puerto Rican participants. And we see significant differences in overall global neurocognitive functioning. And look at the difference. Mexican-American participants are less than 50% likely, right? They have a prevalence of impairment of about 45%. For our Puerto Rican participants, it's over 70%. Yeah.
So to what extent might this be explained by the issue you brought up earlier, the instrumentation?
Right. Yeah, absolutely. So that could be part of it, but again, we're everybody's Latinx.
Right.
Most people are bilingual. We've controlled for demographic factors, and I think that's more of an issue when we look at the between group difference between non-Hispanic white and the Latinx.
Are these all adjusted for education?
Mm-hmm. Gender, age, education, immune function, right? All these really important factors. And when we conducted this study, we used the best available instruments that we have. So the best technology was used, And these diagnoses were rendered by primarily board-certified neuropsychologists who are experts in working with individuals. So this wasn't just anybody doing, kind of the cookie-cutter approach. These were myself, very good neuropsychologists doing the best possible work. And even with that, we see this difference. And I don't have a slide about this, but to me, this makes sense, and I'll tell you why. This hangs with the fact that when we look at health disparities within the Latinx population, so if we compare Cubans to Caribbean Latinx to Mexican American Latinx to Central and South Americans, the worst, sickest Latinx subpopulation in our country are Puerto Ricans. So there is something about this population that they are just not as well. So, and it's not just the HIV. So they have higher, for instance, infant mortality rates, worse health outcomes, and on a number of dimensions. So there's something about this population. And there's something about Mexican Americans that actually, you've heard about the Hispanic health paradox, they tend to be doing better than you would expect. And this was borne out in this research. And maybe we can talk more about that because I've been thinking about that. But thank you for that question. Yes?
Have you looked at New York?
New York.
Just,
Well, so this is the Puerto Rican are New York.
Well, no, that's what I'm saying. What about instead of cutting things on a racial ethnic line,
yeah.
like a geographic perspective? I'm an HIV primary care provider.
Right.
I feel like
Right, our folks are.
if you look at Jack Martin compared to downtown,
Yeah.
like there's this very similar vibe amongst that kind of cuts across race and ethnicity.
Absolutely right. So, and you're talking about socioeconomic status, maybe, or other things that might be contributing to worse health.
Like lead exposure.
Oh, right, yeah,
There's
absolutely.
a lot of interesting. Actually, the Mexican group was a lot of interesting data about sort of the glaze that was used in cookware and things like that. But then I also wonder about lead exposure here in the 70s.
Yeah, well, and just recently in the project, so just a couple of 2 years ago, we lost our NYCHA director because of the scandal with forging, documents about lead, that there was a lot of lead in the projects where a lot of these people live. So absolutely, but even, so I'm gonna show you another slide where when I compared HIV positive non-Hispanic whites to our Puerto Ricans, they still did worse. But I think that doing more of a New York-based study is a great idea, and I'm working on that right now, so I hope we can come back to that. But there's something going on here, right? There's definitely something going on. And in this study that I published several years ago, I compared non-Hispanic white HIV positive Latinx adults to Latinx adults, and what I found was that there were significant differences in the same areas that I just showed you. But once we accounted for SES and rat reading, and really it was rat reading. Rat reading is a measure of quality of education, okay? So it's a short, brief, single-word reading test, and it turns out that it's very potent in capturing the effects of quality of education. Because what we started seeing here in our population, and what my colleagues at Columbia and elsewhere have seen, is that people come to our study and say, I have 10 years of education, and that's really important when we look at and interpret our cognitive data, right? Because we know you're going to do better if you have more years of education. So people come in and say they have 9, 10, 11 years. But when we started looking at their reading levels, we found that there was a significant discrepancy between their reported years of education and their actual reading level. And Jennifer Manley up at Columbia has validated this measure, this RAP3 reading measure here that I show you, and shown that it's significantly related to quality of education. It's related to things like per pupil spending, per capita spending. It's related to teacher-student ratio and a number of variables. So it's been validated. So when we account for quality of education as well, a lot of the impact of ethnicity on these different neuropsychological measures overall washed out in all areas except executive functioning. And here, ethnicity was still significantly predicting neurocognitive test performance in this particular study. So where does that take us now? So I got interested in aging research because it turns out that people with HIV are getting older now, right? So that's really great news. So HIV turned 50 not too long ago, right? And And now we're seeing some of the consequences that we might think of or expect with normal aging or not normal aging in the context of HIV. So that's what brought me to this work in aging. So yes, people with HIV are living longer, but my question is, are they living better? Are they doing as well? And I had concerns about this. So this is a slide that I've adapted from a friend of mine, a colleague of mine, out in Hawaii who worked with Victor Valcourt. And so this is the idea of whether or not HIV is related to accelerated aging. So is, immunosenescence, right? Is that related to worse brain health outcomes as a consequence? And when we think about aging and HIV, we're talking about people who are 50 and older are considered older in this population. So is it the case that due to HIV and this immune activation in the brain that we see, which causes this inflammatory cascade, which is well documented, does that actually cause this immunosenescence that might result in a number of worse outcomes, including earlier cognitive impairment compared to the general population in terms of aging? And so this is not a fait accompli. People are still looking at this, but I think it's interesting to think about this model when we think about HIV and aging. And what I noticed in this emerging literature again is that nobody was really looking too much at ethnicity or how this issue might be playing out in different groups. So a couple of years ago, my colleagues and I published this paper doing a first look in the literature at aging and HIV in HIV positive Latinx adults, okay? And what we found, so here, this is an overview of the sample, and so I'm getting a little bit more in the weeds here because this is more relevant to our discussion today. And so the overall, we had 126 participants. Most of them, 82 were in the younger group and 44 were in the older group. And I split them up into non-Hispanic, white, and Latinx for each age division. And as I mentioned, the age breakdown was older was 50 and older. And now that I'm in my 40s, 50 is not looking so old, by the way. But anyway, that's what it is. That's the literature. And so you'll see that there were two areas where there were significant there were significant differences between the groups. So in the older group, there were differences in terms of age. So our non-Hispanic whites were older than our Latinx adults. There were also differences in the RAT measure. Does anybody remember what the RAT measure is related to? Quality of education, right. So that's our proxy for quality of education. And not surprisingly, so this is a standard score. So like you might think of it like an IQ, like 100 is average IQ. So non-Hispanic whites, their average quality of education was 106, so within the normal range, and it was significantly lower, kind of low average range for the non-Hispanic whites in this group. Over here in this group, there were differences in the years of being HIV positive duration, with non-Hispanic whites being HIV positive longer than the Latinx. But there's also a bias here because they probably just got diagnosed later, potentially, right? But so anyway, so we looked at all of these factors before we started doing the comparisons, and whenever needed, we controlled for any of these significant differences. Okay, but overall, what you see is that this sample, the younger sample was in their 40s, the older sample was in their 50s. High school educated, and actually higher educated in the Latinx group than most people that we see. So that could have been somewhat of a bias in the sample. I talked to you about quality of education. I have a note here about acculturation because I'm going to come back to that because we had to use it in some of our analyses. And basically this measure here, so the AMAS is a measure of acculturation, and it has, there's a scaled score for identification with U.S. culture and another one for identification to culture of origin. And so here I included, just to give you a sense of how acculturated our Latinx individuals were, this scale is 1 to 4. And so they were 3.44. So this is a group, and I talked about this in earlier papers. The population here, the Latinx population here that we're seeing at Sinai, or I'm seeing at Sinai, is quite acculturated. You know, they're bilingual and they're bicultural, right? And so so in both groups, their acculturation scores to U.S. culture were high. The BDI is a measure of depression, and it uses the FAST screen to account for medical or somatic symptoms, and there were no significant differences there. That it's a little bit elevated, but not too much. And so, anyway, so they were comparable in terms of CD4 cell counts, and mostly male. You see the proportion of AIDS and viral load here, but there weren't significant differences. Okay, so that's the sample. Okay, so what did we find? So once we did this more granular analysis to look at between group differences in both groups, what we found was that in the younger group, a lot of the cognitive differences that we'd seen in earlier work dropped out. So there was nothing that was significantly different. We have some like there's a moderate effect size for executive function, and had we had a bigger sample, maybe that would have become significant. But there were no, but I show you this to just show you that there were no significant differences. And here I'm showing you actual numbers, so let me explain these numbers. These are average T-scores, and so average T-scores, basically what we do is we take raw neuropsychological data and we correct it for age, education, and demographic factors. And then we normalize it so that all of the tests and domains are on one metric. And these are standard T-scores. And like IQ, I mentioned, the average is 100, right? And then you go plus or minus 15 for standard deviation. With T-scores, the average is 50, and it's plus or minus 10. So anything under a T-score of 40 would be considered impaired. Did that make sense? Okay. All right. So if you look at the T-scores here, they're pretty close. Non-Hispanic whites did somewhat better on verbal fluency, but they're still in the 40s. They're both in the normal range in all areas except for in learning and memory. They're in the mildly impaired range for both groups, and the non-Hispanic whites did a teeny bit worse in terms of motor function, but they're comparable. Okay. But there is a big effect size here, or moderate effect size. So there could be some signal coming through, but we didn't have enough power to catch it. I just want to be transparent about that. Okay, but overall, take-home message in our younger Latinx and non-Hispanic whites is there's no significant differences. Then we go to the older group, and here what we see are that there are multiple significant differences and some trends as well. So we see that these groups were significantly different in terms of processing speed, which is a really sensitive area of cognitive function for impairment in HIV and other conditions as well, but including HIV. And there was a significant difference on learning, and we saw a trend in terms of memory function. And that there was also an overall trend in global neurocognitive functioning. And in every case, with the Latinx group doing worse, so doing worse in global neurocognitive functioning, doing worse in processing speed, learning, where here they're actually in the mildly impaired range and doing worse in memory function, and here it's mild to moderately impaired. Okay, so they're doing worse. And here I just want to highlight we covariate for anything that could have been associated with neurocognitive performance, and also quality of education, which a lot of studies doing this work have not done. And I also looked at acculturation. So the reason I highlighted that acculturation slide is maybe you say, oh, well, maybe they're just differentially acculturated, it has something to do with that. You would be right to challenge me on that, but I accounted for that. So maybe any residue in our instrumentation was hopefully accounted for by that. And we still see these differences. So even with people just in their 50s, we're seeing significant discrepancies in potentially these trajectories of aging.
What about duration of HIV infection?
Yeah, we looked at that. It wasn't related. Yeah.
Not necessarily, but it almost sounded like you were implying before with the Puerto Rican Mexican comparison that for Latinx populations, acculturation is actually a negative thing. Because the Puerto Ricans are more.
You know what, it's multidimensional and it's complicated, yes, and so this is kind of what I intimated, if we want to talk about it, we could. And so what I think is happening, so I don't have hard data to back me up, so this is pure conjecture right now, so take this with a grain of salt. But if we think about the Hispanic health paradox and why they're doing better, it could be because there's more of a constant influx of new immigrants, right, into the United States. And whereas I think Puerto Ricans here in New York have been more entrenched here in New York. And we have this invisible bridge, right, where there's lots of going back and forth and back and forth. And so I think culturally they're different. I think the reasons that they're immigrating are different, and I don't fully understand it, but I think that there might be an iatrogenic effect of being in the United States and being more entrenched and essentially ghettoized, right? And that could be one thing. I don't know, but it's something I'm thinking about.
It's a bunch of control for.
Yeah, please.
That other study looking at the between population in the Latinx community, so you accounted for the acculturation.
So in that one we did not, which is why I highlight this here that we did. So we did not. So acculturation could have been a factor in that one because it was a big multi-site study and others were not as excited about including sociocultural measures as I was.
Does that measure also include how many generations?
It has
when they immigrated, or
it has lots of questions about things like language fluency, like language use, identification with culture, and I don't recall off the top of my head, so I can't answer that question. But it certainly could be the case that but again, here what we're talking about is disaggregating this notion of culture and even ethnicity more to what it really might be about, right? So maybe it's acculturation or time spent in the United States. And it could be the case that those Mexican Americans that we looked at are less acculturated, and our population here is certainly more acculturated, and that could be part of it. Yeah.
Was there a difference in HIV risk factor between the two age groups? Because my sense is that the older
Right.
Latinx group tends to be more IV drug, and the younger group tends to be more MSM.
Right. I have those data. We didn't look at them, and I don't have a lot of confidence in those data, which is why I didn't look at it, because I think in Latinx communities, there's a lot of stigma around saying that you're MSM. And so I don't know how to get at that better. So I collected the data, but I didn't feel 100% about it. But it is also true that of all the different populations in the United States, that the population that has the highest rate of IV drug use is Puerto Rico.
Sorry, like
Yeah.
County.
No, I love
It's
it.
very interesting.
I love it.
So given that there's no difference based on duration of HIV infection, do you think that part of the difference that you're observing between the older and younger groups in terms of the susceptibility of non-Hispanic white might be attributable to non-HIV related changes to the brain?
Let's talk about that. Good question, Alex. Yes. So I'm going to get to that in a second. So just to put a pin in this, I also want to highlight that the prevalence of hand diagnosis, so HIV-associated diagnosed disorders, is much higher in our older Latinx sample than in our non-Hispanic white by 3 times. And they also, another thing is that they're less medication compliant. So it could be multiple things, including medication compliance. And here in HIV, obviously, you need to have a really high level of compliance. And so we used to cut off of 90%, which is very generous, to look at whether or not to decide if somebody was compliant or not. And we found that the Latinx group was significantly less compliant than the non-Hispanic white group. This could be driving those differences as well. So maybe it's just the fact that they're not as compliant, so that they have more viremia replicating, and not only that, but they're developing more mutations, right? that could be causing worse neurocognitive outcomes. So that's a possibility. So let's talk a little bit in the time that we have remaining about this model and are there other non-HIV factors? So one hypothesis but why we're seeing these differences could be medication adherence. It could be a behavior, right? It could be other things impacting this this process as well. One could be stress related to discrimination. So I don't know if you saw Dr. Urena Clark's talk a couple of weeks ago as part of the diversity in neuroscience series, but it was great. And so I'm going to show this slide and another slide of hers to highlight discrimination. So there are lots of types of discrimination. Overt forms are less frequent than covert, implicit types of discrimination, but they all occur. Again, we live in a racialized society, and individuals from diverse backgrounds are frequently being exposed to microaggressions and different types of maybe more subtle discrimination and systemic structural types of discrimination that could put their brains at risk for worse outcomes and differential outcomes. And what Dr. Clark found in this slide, I'm just going to give you the headline and not get too much into it, but what she found was that greater discrimination was associated with greater amygdala volumes in several brain regions here, and that this wasn't a good thing. There was a significant association. This was just recently published in Biological Psychiatry. So so this is, I think, maybe the second study to look at discrimination and brain function. So this was with resting state functional MRI. And so we're seeing different functional connectivity. And this gets me to what I briefly talked about before, where traditional paradigms of brain function just talk about the brain, focus on the hardware and how it relates to cognitive and behavioral outcomes, this universalist approach, which really is open to racist interpretation when there are disparities in performance. But what we know, what cultural neuroscience shows us, and this is just one little exemplar, is that culture and language change our brain. So we always think, I think, from like micro to macro, but macro issues in the environment impact the way we problem solve. They impact our ability to deal with a number of things. And it changes, culture changes our brain. Language changes our brain. And here we see that discrimination is resulting in different functional connectivity. Not only that, but in another study that myself and my colleagues conducted with HIV negative individuals, is that we found that both perceived discrimination and stereotype threat negatively impacted cognitive test performance. So again, discrimination not only impacts brain function, but it's also associated with neurocognitive outcomes as well. And so more discrimination, worse performance is the headline there. And stereotype, has anybody heard of stereotype threat? Yeah, just briefly, stereotype threat has to do with the expectation, in social situations, the expectation that you have. So there's been really interesting work, experimental work done that shows that if a person from a minority background, whatever that might be, is put in a situation where there is an expectation for worse performance, so say, where there's a stereotype about worse performance, like women with math or African Americans with a complicated cognitive task. Again, because we live in a racialized, gender disparities culture, that it'll result in worse performance on cognitive measures, and that's what we found here as well. So essentially, when we went into a stereotype threat condition, people did worse in cognitive performance as well. Quality of education I've talked about a little bit, and this is a really busy slide, so I'm not going to talk about it here. But also SES. So what do we know about SES? We know that SES is associated with health characteristics, and that it also attenuates group differences when we look at between group differences between African Americans and non-Hispanic whites. Once you count for SES, a lot of the differences are attenuated. The short study in 2004 was a huge and great study, showed that. Another study in 2006 showed that SES mitigates age-related decline, And I did a study back in 2008 trying to look at SES and zip code, which I highly don't recommend doing. So that's why I highlight that here. But we did a more recent study with a better measure of SES. And basically, if you recall before, there was some research showing that ethnicity was related to learning and memory. But once we counted for SES, it was a completely mediated, that association, so that ethnicity was no longer related to learning and memory. So to sum up, we know that there are significant disparities in brain health, and that older Latinx HIV-positive adults are at greater risk for cognitive impairment. And based on our discussion, I hope that you also remember that sociocultural factors are related both to brain function and cognitive function. So where do we go from here? Let's see. So I have 4 minutes. All right. So where do we go from here? Well, we don't lose hope. We remember that the pathway to greater equity and justice, to me, is through science. And the more and better science we can do, the more and better healthcare we can provide. And if you're interested in supporting a great study, I happen to have flyers and brochures for a study I'm conducting now, looking at HIV-positive older adults to try to understand genetic, neuroanatomic, and sociocultural factors that predict cognitive aging in this population. So please take some before you go. And another pathway for improving health equity and brain health outcomes is through increasing the cultural competence of everyone who's doing research or providing healthcare or both. And so if you check out this study, I talk very specifically about ways that we can improve our cultural competence, and it was targeted towards neuropsychologists, but it's really for anybody doing work with people who have brains. And I want to bust up this paradigm, and really the way I think we need to think about brain behavior relationships is to include sociocultural factors, because we know they impact brain function, and that as well that we can make differences by making policy changes at the social level, and that there is good news that our literature is expanding. There is more awareness of cultural diversity and brain health. We had a big summit last year to focus on these issues and created work groups to work towards this in my field. And just on Tuesday, there was a huge Twitter storm to focus on research diversity in aging with NIA. So I partnered with NIA, and that was really fun. If you want to find me, I'm at Dr. Rivera Mindt on Twitter, and it was a great discussion. And I'm just going to leave you with this to sum up my hustle. So what's my hustle? My hustle is to advance equity in brain health research and practice to reduce disparities and improve health and wellness of all groups. And so I've talked a lot about the challenges, and I think there are multiple factors that we can intervene upon to really then translate that to policy and standards to improve health outcomes in a number of ways. But I think as scientists, and clinicians, we need to do a better job of talking to our elected officials and policymakers to affect change, and to get involved in our leadership and in our guild organizations to make sure that this message is coming across about the importance of this for the brain health of all Americans. So with that, I want to say thank you and acknowledge my funders, and thank you so much for having me here today. I really appreciate it. It's been great being here.